بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين. نحييكم بتحية عطرة. السلام عليكم ورحمة الله وبركاته. Ladies and gentlemen, greetings. On behalf of the Saudi Prosthodontic Society, I would like to welcome you all to a very special evening. This is your host, Faisal Azghabi. It gives me a huge honor to be here today, as today is so special that we have both societies' presidents. Our guest tonight, Dr. Rossopoulos, the president of the American Prosthodontic Society, and our president, Dr. Mansour Asiri, the president of the Saudi Prosthodontic Society. Please all welcome Dr. Mansour Asiri. The microphone is yours.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. اللهم ارفع عنا هذا البلاء واحفظنا واحفظ العالم أجمع. اللهم برحمتك وقدرتك يا سميع الدعاء. اللهم رمضان بلا وباء. I cannot recall any Saudi Dental Society signed an agreement with any American Dental Society. So I can proudly say that your society is the first Saudi Dental Society to have the opportunity to sign an agreement with the American Prosthodontic Society last February. With pleasure, I'd like to introduce a colleague of mine and a good friend, our speaker for today. He is the current president of the American Prosthodontic Society, Dr. Rossopoulos. Dr. Rossopoulos, he got his DDS from Greece and his prosthodontic certificate from Eastman DentalCenter in Rochester, New York. Dr. Ross is a full-time private practice in Los Angeles, California, and he's a board member of several dental societies in California and the United States in general. He's a faculty staff at UCLA and Eastman Institute of Oral Health. Rossopoulos, the webinar is yours now. Please start.
Well, thank you very much for the beautiful introduction. This is the first time we do that. We did sign a mutual agreement back in February between the Saudi and the American Prosthodontic Society to collaborate for education, and that's what we are all about. This opens a lot of avenues. And this is a way that we can collaborate, exchange information together. So on behalf of the American Prosthodontic Society, I would like to send greetings to all our Saudi friends. This is a picture of this very nice agreement that you can see our then President, Dr. Barzilay to your right, and Dr. Asiri to the left. And on the upper left corner, some of our Saudi friends that happened to be at our meeting last February. A little bit about myself.
Sorry, Dr. Rossopoulos.
Yes.
Could you just share your screen, because the screen is not appearing to us?
Give me a second, please. Let's see.
Take your time, doctor.
Sorry for that.
No, it's no problem.
Here we go. Are we okay now?
Yes, perfect. Thank you.
So as I was talking, this is a picture of Dr. Asiri and Dr. Barzilay, our president, back in February. I took over for Dr. Barzilay as the president, so I'm the current president of the American Prosthodontic Society. So I would like to extend greetings to all our Saudi friends of the Saudi Prosthodontic Society. A little bit about myself, just very few things. I graduated from the University of Thessaloniki Dental School, and I did my studies in prosthodontics at the Eastman DentalCenter in Rochester, New York. Since then, I have dedicated my time to direct patient care. So what we will hear today, it is not from an academic point of view, but mainly from a private practice perspective. It has to do on how we were able in our practice to incorporate a digital denture technology. What were some of the drawbacks? What were some of the advantages? And also what we use as protocols for this very nice up and coming procedures that we have. First though, before we get into that, there is a question about what is going to happen to complete denture therapy. Is that going to be a cockroach, or is this going to be a dinosaur? And I'm referring to a dinosaur being something that went extinct several million years ago, versus a cockroach that it's believed to be the only living creature that will stay alive if something happens to this earth. And the reason that this question comes to mind is because of implant therapy has actually replaced a lot of the traditional denture therapy. We heard great presentations regarding implants over the past week and a half, very high quality lectures. I would like to applaud the Saudi Dental Society for those. Great speakers, great information. This is probably one of the first ones that we will be actually talking about dentures. Let's look at denturism as what it is and how much of a health issue it can be. Actually, it's a public health issue globally. We're talking about pandemics at our times. Denturism can be considered a pandemic. In people, in Western civilizations, let's say take United States, we exceed 10% of our adults with no teeth, those that are over 50 years. And as the age gets higher, 60 years of age, 25% of those people are missing part or all of their teeth. So it is actually a pandemic if you look at it in that direction. And there are a lot of consequences of having missing teeth, significant nutritional changes, obesity, diabetes, coronary artery disease. And lately we've seen a lot of studies coming out about sleep apnea. Those are edentulous patients.
Sorry to interrupt you once again, Doctor. However, yes, you could share the video if possible, if you'd like that.
Okay, I've got to get out of this again.
You could go to Zoom software and then press on start video. Yep, perfect.
Apologize for this again.
No, with the beautiful blue background. Thank you.
Are we good now?
Yes, we are.
So we were talking, we are also not doing a very good job in our education. There are really not too many studies that have to do with denture therapy lately. So there is a lack of research and studies on that field. And in the United States, there is a tendency actually at our dental schools to remove the prosthodontic curriculum, the removable prosthodontic curriculum from our study. As a matter of fact, it looks like about 15 to 16% of the dental schools in the United States are allowing their students to graduate without even completing one full denture. And they see less and less. So those that they treat denture patients, they don't see as many as they used to see before. So we graduate dental students or dentists that do not have a very good background information when it comes to this topic. The profession in general is abandoning this area. Why dentures can go extinct and be a dinosaur? It's because the theory was that an asteroid came to Earth, fell into the earth and then the dinosaurs were all gone. Where this asteroid in our case, it's actually implant therapy. But dentures, I think, will survive because they are very adaptable, especially with some of the new technology that I'm going to talk to you about. Can they survive this attack by the implants? Yes, because I think there will still be patients that need good removable prosthodontic treatment. And as dentists, we have to reflect on the patient's needs. Sometimes it is indicated to provide full removable prosthodontics versus implants. Some socioeconomic factors might determine that. We also, by adopting and embracing some of the new technologies we are going to talk about, we can make dentures fun again and position actually our private practice in the forefront. And looking into my personal private practice, incorporating this particular technology had some good financial impact too. We also will reduce labor and cost. So let's see what's going on. Let's enter the beautiful world of digital dentures. And I would like to mention again, this is from a private practice perspective only. So please, I would like to apologize for the slides, darkness or lightness and so on. I'm not an academy or a speaker, and I would like to look at it only in a practical approach. Back in 2011, Dr. Ron Jarvis, one of my mentors, came and showed me what they used to call the AMD Avaden prototypes. Avaden is one of the companies that has a digital denture technology out there. And at the same time, the people from that company invited us to come and tour their facilities. Well, guess what? I did not tour the facilities. I actually went car racing with my classmates. But I bought the kit, and that had to do with the Avaden Corporation. And at that time, there were only two companies with this technology, Avaden and Demca. I decided to go with Avaden. And this is the original protocol of this company. On the left side, you see a maxillary and mandibular impression made with PVS material. In the middle, you see those AMD, as they call them, trays, that they were relined with impression material for better adaptation. And on the very right side, you see what they used to call a maxillary and mandibular AMD trays. And those were actually two trays that we will reline in the mouth, and using a Gothic arch tracing, we will determine the centric relation of occlusion. In order to give guidance on how the anterior teeth will set up, we will use a stick-on transparent teeth, 6 anterior teeth guide that it will be glued onto those two trays. And then we will make a bite registration on the centric relation that was determined by the Gothic arch tracing. Everything will be put together with a bite registration and glued them together. And this assembly here on your lower right side will actually be shipped to the company. When it reaches the company, they will transfer those records to an image, a computer image, and those now become our virtual maxillary and mandibular casts on an articulator. Then they will be setting up the teeth using a specific software that will allow us to do a virtual teeth setup. And the information after the setup will go to a milling machine. A base will be milled from a pack or from a disc that will be put in that milling machine that will actually mill the base of that denture. Then the sockets of this base, which you see on the upper right side, will be corresponding exactly on the socket of the denture teeth from the company that we use the library. Those teeth will be luted into place with self-cure acrylic, and the denture will finally be polished and sent to us. This was my first case. This is using PIP paste, pressure indicated paste, actually spray, to find out where my high spots are. This was the first one when I inserted the dentures, and I could see already very good adaptation. Maybe a couple of very small areas that had to be adjusted, such as here on the lower left and the lower, but overall, very, very good adaptation. On the occlusion side, what I noticed was overall an acceptable result, if I can put it that way. Some adjustments had to be made. For example, on the upper left, as you look at second bicuspid. And then after a couple of adjustments, I actually got pretty good conducts. There was an error in this particular case. That was my first case. And that is the way that the mandibular right teeth were set up. They are outside the ridge. That is not appropriate for a denture therapy. It actually had to do with the initial software, because with that particular software, they would set the maxillary teeth first on the ridge, and the lower teeth, the mandibular teeth, will follow that. So that was an error that it's fixed since. And that was my first result. It was a 2-visit denture, and that I saw a great benefit to that for my patients, especially the elderly. This was the other system in the market at that time, very similar technology. You will use special trays to make your impressions, but there was a way that you can separate the maxillary in 2, the mandibular in 3, and use this anterior part of the tray to make your occlusal registration and your Gothic arch tracing. It had incorporated already the stylus and the table, and it was very similar in the approach. The second step on that particular technology at that time, we are talking about 10 years ago, was they will send you a printed try-in. This is a full printed denture that will flow some wax around it to make it look like a try-in, that you will try in for the patient for aesthetics and phonetics, and as you will do with any try-in. And then this will go back to the company, and it will be flasked in a regular way. And you will have the maxillary and mandibular dentures. I like what I saw as far as quality of the denture. What I personally did not like at that time was the fact that was not a complete digital workflow. That actually has changed since with that company also. So a lot of questions came to mind, as we will do anytime we try to incorporate a new technology in our practice. Is this economically feasible? Can we incorporate it in our practice? Can we have control over the process? I didn't have too much control over the process on that first case. Quality control definitely lacked. Can we simplify the protocol? The protocol, the initial protocol, was actually very technique sensitive. How about a single arch? It was marketed for a maxillary and mandibular as a total. How about a try-in? Can we do a try-in? Use it with implants? Can we use the technology with immediate dentures? Can we customize this to the individual needs of patients? We have no clinical studies or documentation at that time. And where will we be in several years? Well, I decided to test this to the limit. So think that at that time, the protocol called for a specific way to be making your records, and for a specific way that they will produce this denture. It would be a maxillary and mandibular as a set. I decided to do a single arch. So I called the company and tell them, let's do a single arch, my fault, whatever happens. They said, fine. And not only I pick up a maxillary single arch, I pick up an overdenture and a small obturator. And I decided to get away from their original protocol by at that time duplicating the patient's existing denture, as you can see on the lower left side. in a lung duplicator, a very easy way to do it. And using that as my final impression tray, as you can see on the lower right side, and a tray that I will give some guidance on where I want the teeth to be set. I took this and actually flew to Scottsdale to see how this works. That's my picture of myself 10 years younger with the desktop scanner that I will put my impression and records in and scan this assembly and create a digital record that then it will be worked with a setup software. So this is a virtual teeth setup. And then it will be placed in a milling machine that the base will be milled and the teeth will be luted, and then we will have the final product. I watched this as it happened, and I liked the way the workflow was. This milling was happening overnight, so I flew back and had them send my denture, which arrived about 2 days later. Here was my denture. The intaglio surface, again, very nice adaptation because we do not have any dimensional changes. This is milled out of a solid pre-cured pack or disc, if I may put it that way. There is no dimensional changes that we usually will get with any other traditionally made denture. Usually we will get a lot of high spots in the tuberosities or at the back flange area that we have to adjust. This was pretty good adaptation. And there were some errors, if you can see on the lower left side, in the lingual of the maxillary teeth, because I overcompensated for the space for my attachments in the denture. So we needed a little bit more thickness on that. Here's how the denture looked after I directly luted the attachments into the denture. Pretty good result aesthetically, not the best, but acceptable for this particular patient. The only problem I had was on occlusion, and that was on the maxillary right side. The teeth did not, as you can see on the upper left side, the teeth did not fall the mandibular teeth. And that happened because the original protocol or software was setting up the posteriors in a block. So they had no ability to move the teeth as they are on the lower left side. So as a good prosthodontist, I ground this off and luted them in place in the right position, deliver the denture. Usually we do not see too many sore spots the next day because of the adaptation. We spent the last several years into developing specific protocols that will actually accommodate our patients and our way of practicing in the office. And we broke into 4 different groups, and I'm going to go over those. For a single arch, so if we have a maxillary and mandibular denture or a set of maxillary and mandibular denture that the patient has already dentures, we are following a denture duplicated protocol. We duplicate the dentures, as you can see on the upper left side, the maxillary, on the upper right, the mandibular. We duplicate the patient's dentures. We create room for our impression material and stops, and we proceed with our impression material. So if you can see, upper left side is the tray as we do the first step. We will put heavy body PVS material and we will border mold. Then we will come in and relieve this area. So we will allow room for our new material. We will take care of undercuts. I will grind those off. And then we will come in and actually slightly butter up, if I can put it that way, the light body material in the middle and heavy body at the periphery. And in one shot, we will do our border molding and final impression, as you can see here on the lower right side. And this is the mandibular impression on the same patient. We will then go through our occlusal record with these little impressions we have, and we will make any changes that we need to do to guide the software or to give new information on where we want the teeth to be set. In this particular patient, as you can see, there's a black line. Actually, this is a groove. We put to move the midline about 2.5 millimeters to the right. The midline of the old denture was not in the appropriate position. And we need not a marker, we need a groove, because the scanning will not read visual, it will read a 3-dimensional. So you take a little disc, put a groove, and then as we design, we know that's where our midline will be. We have the incisal edge position, that's the other information we need, and we have the occlusal plane. We can make adjustments also by writing things down. Let's say we want to elongate the centrals 1 millimeter or so on. On the upper left side, you see the scan of this assembly. And then we go through a virtual setup using a particular software. On the upper right side where you have blue is actually the old denture guidelines that we have. And you can interchange that where we see white and set up the teeth in the position that they were before. This is a very easy way to do it. This is my final result, as you can see on the upper left side, on the left side of your screen. Acceptable. We are treating a lot of elderly people. Please keep in mind that many times these are very acceptable prostheses for them because they are looking into mainly comfort and not the way they look. Another way of doing this, if the patient has existing dentures, is actually take their existing dentures and use a soft tissue conditioner and have the patient wear this for approximately a day, come back, we will make the bite registration. The patient is waiting in the chair. We will take this assembly that you see to the right side back to our desktop scanner. We will scan it, and here is our record. The patient will leave after we clean this. It takes about 15 minutes. This is the scan of this particular patient. As you can see, one assembly, it's a single scan most of the times. Sometimes we have to separate if we have a lot of undercuts and do separate scannings and then do merging to put everything together. Here's the final on this. Pretty good occlusion, as you can see in the middle upper of your screen. And just a little tip, some of our elderly patients, for their overdentures, the implant overdentures, they have hard time taking it out. We will come and put 2 little tabs there at the posterior area. We keep those smooth for them to be able to get underneath and push the denture out in place. We do those, we haven't milled those yet in the denture because we don't do it unless it's necessary. We use self-cure acrylic to do those if we elect to do so. Or a third way, with our third protocol, we can actually take the patient's beat up denture. And in this situation, because of all this wear on the maxillary denture, we had to increase the vertical. I use a little piece of wax, so when the patient comes and bites on it, I can determine what vertical I want it to be. And then by having the wax in place in the new vertical, I make a bite registration for that patient. You can see it here a little bit better. The wax shows a little bit. This is in an increased vertical than what the patient was. And this is my bite registration. I use a polyether in this case. We take this, we scan it, clean it, and give it back to the patient. In this situation now, in the first protocols, and it still can be done, usually we will mill the base separate and we will load denture teeth on it. But now, after the denture setup is done virtually, the technology allows the company to make a custom-made pack, a custom-made acrylic pack that incorporates both the tissue acrylic and the teeth-colored acrylic, and then do a mill of this pack. What you accomplish by that is you don't have to loot individual teeth. It's a monoblock, as they call. I will call it a single block, not a monoblock, because it's not exactly the same materials that they are placed there. This seems to be the way to go at this time. Aesthetically is not as good as using the previous way or the way of luting the teeth on, but it actually makes sense because it provides us with a much stronger maybe approach. This is the final one on this particular patient. You can see the aesthetics is not the best, but very acceptable for an elderly person. And this is our first single PIP pressure indicated paste, which shows a very good intaglio surface. For those patients, edentulous patients that actually do not have dentures, this gentleman was referred to me by his sister. The sister said he is miserable. He went to Mexico 3 years ago, had his teeth taken out, and nothing is done since. And he's very unhappy because he cannot be in society without teeth. I'm going to show you the protocol we use for these people that they don't have dentures. This is the maxilla and mandible of this patient, poor form, very flat palate, no undercuts. Mandible is very resorbed also. What we use is they are called good fit trays. They are actually impression trays made with thermoplastic material that they have denture teeth on them. I can take this and through boiling it in to adapt it on a cast if I want it to fit better. And then I will use this as my impression tray and record also at the same time. Let's go over it. My first position will be to use heavy body under this particular tray in order to align the anterior teeth in the best aesthetic position that I think it is. So it's like taking a denture and realigning in the mouth by paying attention on how the maxillary anterior teeth are aligned. I then go ahead and take off wherever I have areas that I have to, and I make my final impression. So this is a final impression that duplicates a denture that I think how the denture would look. Same with the mandibular. You don't have to pay as much attention in teeth setup on the mandible, but we would like to approximate that. And here's the assembly after we're making the bite registration record. As you can see, it gives us information on intaglio surfaces and teeth positioning as good as I can determine. Obviously, with experience, you get a little bit better to that. I can also, as you can see on the upper right side, modify this incisal plane or modify the teeth position if I happen to put it in an area that I didn't like as I look it back. So what I would like to give to the software, to the design software team, the information is as follows. I would like to give them the midline, the incisal edge, occlusal plane, and possibly teeth arrangement. Those are the factors that they will be put into the design in order to do the virtual teeth setup. This is my scanning. And for those patients that they do not have denture, we actually have milled complete dentures, the same way as your final denture will be made. They are just tooth-colored material to decrease costs that the patient will take and try them in at home for 1 or 2 weeks or whatever is determined necessary. So this is actually a very nice way of doing a functional try-in, if I can put it that way. So we did that with this particular patient. I would do adjustments if they need to. We will rescan if we need to. There's a lot of things we can do with those functional try-in dentures to get to the result we want at the very end. Those are the final dentures for this patient. Very good intaglio surface, good occlusion. And this is the final appearance. The patient was very happy, back to the society, able to smile. For immediate dentures, what we use is usually alginate impressions, as in this patient. Very severely periodontically involved teeth, class 100 mobility, I would say, on the anteriors. This bridge was flowing in place. This particular patient wanted only to address the maxillary arch at this time, which we did. We persuaded to at least do some periodontal therapy in the mandible. This is a little trick how we make alginates if we are afraid the teeth will be coming out with impression. I use one type of impression material to block out the undercuts on the facial aspect, and I use a different type of impression material to block the undercuts on the lingual. This is PVS, this is polyether. The reason we do this is we don't want to use the same material because it gets underneath and locks in place and you cannot remove it. After we place these two materials in the undercuts, we will make our alginate. We will pick this out of the mouth, the little blockouts we did, and they will fit like a puzzle back in the impression. We can use some crazy glue to root them in place, but what this will do will give us a very nice, if you can see on the lower left side on the cast, a very nice detail on your cast that we don't use to get with other ways that we use to block out. Of course, intraoral scanning will be the way to go in this situation at this time. So this is my scans. And this is the final immediate denture, probably a couple of days after it was delivered. The patient was very happy with the appearance, not very happy with the color. So very easy. We did have to obviously make this denture again. We took the opportunity to do a little reline on it at the same time. It was an immediate denture. And we came up with a new denture with actually lighter teeth to satisfy the patient's need. And this is how it looked on the second set of dentures. She wanted exactly to follow how her teeth was, which was a reverse smile. So we followed that up. That's not what we would have done otherwise. The problem is with high demand patients. This technology actually is not set for that yet. We are getting there with newer multicolor materials, but we are not there. So at this time, for those patients of ours, we will use the impressions and then make what we call processed bases. So they will mill those bases out of that pack. And then we will go ahead through a traditional, and I'm not going to stay here too long, through a traditional setup and traditional fabricated denture after that. So the base, the processed base is actually made with a CAD/CAM technology. Everything else is made with a traditional denture. Back in 2012, I made a couple of presentations as I was getting into this technology and look into what will happen in the future. And these are some of the things I thought will happen. We would need clinical trials. We will need to simplify things. We need a fully milled aesthetic denture. How about implants, implant prosthesis and frameworks? And we need to not send that in one company. We need many companies. And how about 3D printing? Because that I saw was the future on this. Fortunately, several articles came. I'd love to see many of my Saudi friends and residents at that time, names in some of those. And then some clinical studies came. I will not spend time on that, just go and read literature on it, but still lots need to be done. What changed was actually the workflow. If you look here, I have green only in the impressions and records and in the delivery phase. I have green only on the things I used to have control back in 2011. Everything else was red. I did not have control over it. And that's I didn't like. We are control freaks as prosthodontists. So here's how things change. As far as the digital records, you can actually use an intraoral scanner and do this if you wish, or you can use the protocol we use and then use a desktop scanner after you make your impression to create a digital image. Using an intraoral scanner probably will be the way at some point when we figure out what information to give on the software to reduce the extents or the flanges on this, because this will create an overextended denture. We cannot border mold yet with an intraoral scanner in a way. So we are still personally using a regular border and molding impression technique and digitizing those. And here's my assistant actually doing that at the office. So you can have your personnel or your technologist actually do that. Then the digital design at this time, this really flew very well, because not only you can outsource where you only used to be able to outsource it, but there are commercial laboratories, there are actually design companies, and also you can have the software at the office and being able to do your virtual setup. Here's myself doing a virtual setup on a denture at my office. And the fabrication, same thing. You can either do it yourself or you can outsource it. So now we have the abilities to go from that really constricted workflow, if I can put it that way, that we had no control, and pick and choose. So we can make our records, we can do our digital records ourselves, we can do our digital design ourselves, you can do our fabrication ourselves, or you can outsource any of those three in the middle. Obviously, the first and last part, we are responsible and we are the ones doing it. But everything else, we have the freedom to do it ourselves or outsource and pick and choose what we want to do in our practice. And that helps financially, because if I don't have the ability to have a desktop scanner for financial reasons, I can outsource that. And a little bit about frameworks and implants, that's the thing I didn't talk about. This is a little bit newer over the past 2 or 3 years, actually. This particular company realized the need to be able to incorporate metal frameworks or titanium bars into their acrylic pack. So here's my approval image that was sent to me to approve the design for this framework. So this framework is actually printed, 3D printed framework, and then the pack or the disc, the milling pack is made actually around this framework, and then it's milled. So first, the frame is made, the pack is made around that pack, and everything is milled on a monoblock in this situation. This is an implant over denture patient. We also have the ability to use that for some fixed implant prostheses, the hybrids or the fixed detachables, however you want to call them. And there are 2 ways that we can do that. In the traditional bar, titanium bar design, that first the bar will be made, then the pack, and then it will all be milled as an assembly. Or this new wraparound kind of honeycomb design that will allow the acrylic to, when it is processed in that pack, to run in between the bar also. Those are only been out for very limited amount of time, so I don't know how things will work, but for the past couple of years, they are doing very well. They keep staying very stable. This is a pin type of prosthesis that I have done a handful of them, and I use those for fixed situations when the patient wants a fixed prosthesis, but when I have to use a flange. It's a dual bar technique. So the bar is at the patient's mouth. This secondary bar is processed into the pack and eventually milled with the denture. And the idea will be that this particular pin that can be replaced, which is in the denture, will slide into place and lock into your first bar. This is a virtual design of it. So this, because we are still start working on it recently, this is an error on this. I would like to see this bar to come a little bit more anteriorly underneath the anterior teeth. This is the patient, this particular patient. You can see the bar in the mouth. You can see the prosthesis in the bar in the mouth. So there's a secondary bar in this prosthesis that snaps into those 4 pins. This is the way it appears in the mouth. So the only reason we are using this and not a screw retained prosthesis is because we have to have a flange on this. We needed the lip support on this patient. The other way to do this would be with an overdenture. Patient wanted more of a fixed, and this is almost like a fixed. The patient can remove it. It is hard to remove and clean and has to do that every day. The other way I use this technology is actually to replace the acrylic that's worn out in the old screw retained fixed implant prosthesis. I've been doing those prostheses since the 80s, and some of them had their best time, such as this. This is about a 15-year-old that we need to come and replace the acrylic portion of it. And the way we do it, we create an impression with that prosthesis into place to capture any changes underneath. We will pour a cast actually of that. We will screw this back with some analogs and pour a cast, and then we will digitize it and send it to the company. So the company will remove all the old acrylic and create a new pack around the existing bar. We actually salvage the bar this way, such as this. So you see very poor implant positioning on those, but we were able to actually replace this with a single block acrylic, which will make this much nicer. There still will be wear on it, but it will be homogeneous and we will not be having teeth popping off, which seems to be a big problem with those fixed prostheses. We also keep a virtual record on this. So next time we have to do this, it's very easy. We just send the bar to them and they go ahead and do it. A little bit about 3D printing. We are getting there slowly, but we are not there when it comes to dentures. The materials are still very brittle. I am not going to go into it. There are some newer materials that present some hope for the future that will be stronger, but several of them I made that they were thin bases, they actually fracture. So we don't have strong enough materials yet for printing, but definitely this will be the future, because the way I look at it, we will be able to print in multi-layer and be able to print much better prostheses. At this time, we have to rely on surface staining to make those look good. Plethora of printers, plethora of materials, and some new stuff is coming up. This will be coming up at some point that look into about 500 printed units, and they have very minimum amount of fractures. Looking forward to this and see what the protocols were. There are other systems in the market. I use the Avadent personally. Not that it's the best, that's the one I'm used to. The Baltic denture, you can go and read about it. It's a denture in a pack that it's printed and has a certain protocol that you can kind of copy your records to this. Dentsply is in. Dentsply has a nice material that they brought for printing now, which shows a lot of promise. We would like to see that improving even more. Vida has the ability to actually mill the individual teeth on the underside, so your denture base will be of the same thickness and stronger. And Ivoclar has a very nice looking denture, both milling and printing, mostly milling. They mill the base and they mill the teeth in one block, and then they lut the two together. And as you can see on the lower right side, they now start creating a newer pack where you see those extensions is to try to do a better job in the proximal areas that sometimes does not look good with those milling dentures. There is a Facebook pages regarding digital dentures, several around. There's a digital denture symposium that runs every year. So looking into that, there's definitely a lot of future in this. You can see a lot of companies jumping in it. You can see all those seminars, you can see all this information around. So I think this will definitely be the way of the future. Here are some of the advantages. We did speak about it. I'm going to point out to the one that I think is the most important, and this is number 3, less number of visits. In our private practice, we see a lot of elderly people, and for them to come multiple times at the office, it is not a very easy proposition. So being able to use this technology and creating for them dentures in 2 visits, it's a huge, huge advantage. The other thing nowadays that we have to think about is how will be the next day in our offices. We actually cannot see as many people at the same time. We need to allow time between patients. We need to limit the amount of visits we see patients with this virus that's been around. So I think the less number of visits might have some saying into this also. If I can make a denture in 2 visits instead of 5 or 6, that will decrease my chance of transferring a disease from one patient to the other or the disease coming to the office. It's going to, it actually is incorporated with implant prosthesis now, which I see a great advantage to it. We are able to have single block acrylic. This is, the last one is actually a good thing for our office. It presented with marketing opportunities because you can be known as somebody that does digital dentures. It sounds good, and it actually is a nice service. So you might be able to advertise to people that way to increase your patient flow. This is not a scientific study, but this is personal experience over the last 3 years. So because a lot of things changed from 2015, about 5 years now, I haven't updated this, but in 2018, I sat down and marked down how many patients we saw, including implant overdentures. And all those were, if you can see here, one operator using one system. We used the denture duplicate or the good fit tray protocol. And I included both immediate and regular dentures. Our study, and it was a very subjective study. So I mentioned here satisfactory, and that had to do with 2 things, patient satisfaction or operator satisfaction. It's a subjective way of looking into things. And 81% of the time, actually in both of them, both the regular dentures and the immediate dentures, we were satisfied. And we had about a 20% non-satisfaction rate. What was interesting is the reasons that the non-satisfaction was. For the regular denture patients, it had nothing to do with what we did, just our psychology ability to realize that the patient had very high expectations and we did not realize it. This was almost for all the cases, and then maybe one or two of them who had occlusion problems, and some of them, they had internal inductive surface problems that we needed to reline. However, on the immediate dentures, most of the problems we had to do with occlusion. These numbers are a little bit better as we and the technology is getting better. And I think we will get to the point of the 90% success rate, if I can put it that way, on a very subjective type of study. What is going to happen in the future? Here is what on the upper left side I had back in 2011. I think we need more clinical trials and they will increase. 3D printing will replace milling. Multicolor printing of an aesthetic denture will be a way to go. I would like to see new superior materials. We will come to the point that we will do an one-visit denture, the same way as we do an one-visit crown at this time. And don't be surprised if you look some of do-it-yourself, some of the do-it-yourself orthodontic treatments in the market now, that will also come in the market. The socioeconomic factors will determine our modes of treatment. And I'm almost sure that the digital denture protocols will replace the traditional ones. Only a few traditional ways we will be able to be using. Here's my final thought, and I want also you to think about the same way. The digital denture systems will evolve to be very popular and superior for the benefit of our dental patients. However, saving the natural dentition and tooth loss prevention should be our primary goal. That's something we are not doing a very good job of as our specialty, but we have to start looking a little bit more seriously into tooth prevention so we actually can avoid having a dentures patients. Thank you very much, and I'm open for questions.
Thank you very, very much, Dr. Ross, for this wonderful presentation and very valuable information that you gave us. If you could just please stop sharing your screen so I can share the question that you've provided that will appear in our Twitter account for any of who can answer the question. And please go to the section of Q&A to answer any question that you'd like to answer.
Give me a second, please.
Take your time.
Stop, sir, right here. Thank you. Here we go.
Yeah, thank you. So back to you, Doctor.
Okay, so again, let me just go through the questions. What year I started the first denture case? That was 2011. If I can answer that question. The second question was for the case of the small obturator. Is the occlusal movement modification in the right side, will it affect on the eccentric movements? This is open to discussion. So with this protocol at this time, there is some virtual articulation into this. However, it's mostly on centric relation. And it is based on the fact that there are really not too many studies that they show that actually fully balanced the denture, you will have a better result than if you fully balance it. I'm not saying not to fully balance your dentures at this time, but I haven't seen any problem at this time with that. How do you, let's see. What's the name of the thermoplastic impression tray? It is called Good Fit Tray, like good and fit tray. I do not know who sells this in your area. So during the first Evangelos patient, the one that went to Mexico, that's the one that did not have dentures, how did you restore the interocclusal space? I am assuming the question relates to how you determine the vertical dimension of occlusion. It does have to do with experience. So we are looking into averages, and also we are looking into corner of the mouth and lip position. So if you put those trays in and have the patient at rest, you're looking into how much the lips are apart or how close they are to each other. And also you look at the corner of the mouth. And after several years of experience, many of us are able to tell if we are open or closed in the vertical. We also can make some measurements on that. And average from the up maxillary flange to the mandibular will be around the 38 to 40, 41 millimeters. For these dentures, let's see. I don't see any other question at this time that I should for the case. How do you control the flange extension when you make the final impression digitally? I talk about it. Actually, I do not. I do not use this way. I think what will happen there is we will be able to make the intraoral scan, and then there will be some average that we will be using. There will be some kind of a software that will give us averages on how to kind of border mold the digital impression, but you cannot at this time. There will be developments on that. Another important question, is that mean saying goodbye to the technicians? Actually not. When this technology first came, it was only marketed to dentists and prosthodontists in particular. We went to the company and really strongly suggested this is not the right way to do it. We have to have the technicians involved. So the way, and it is happening now, and the technicians actually are doing a marvelous job taking this technology and advancing it to points that I've never thought it will be. Many of them are very involved. The technicians will be involved, and I think it should be that way in the middle part of the process. So they will be the ones that take our impressions, digitize, do the visual setup. We will come and approve or disapprove that setup. They will mill, finish the denture. They should be there on our side, working together as a team for this technology. It is very important. Should I answer more questions or?
Yes, if you'd like that, or we just can stop if you see the amount of questions are enough.
What about selection of denture occlusion type digitally? Is it applicable? Yes. You choose, depending on the software you have, you do have several libraries of teeth. And those not only relate to appearance, you have, let's say this particular X company's tooth library, which corresponds exactly to the tooth that they have for traditional ways. But also there is a library to have different types of occlusion. So I can pick lingualized occlusion, if that's what I want to do, flat occlusion, or anatomic occlusion. In my particular software at this time, those are the three choices I have. So yes, you could digitally determine what kind of occlusion you're going to be using. Another question, it's related to the drawbacks of using digital to fabricate the prosthesis. If you can summarize them from your experience view. Yes, there are definitely drawbacks as with everything else. There is a learning curve. That's kind of a drawback, because you have to start thinking digitally and not traditionally. A lot of things we think traditionally, and when you get into the digital world, it's not working. So that is one drawback. Obviously, capital investment, still fee-wise, there is more expenses related, laboratory expenses related to this type of the prosthesis than with a traditional one. Still, I see a drawback in not being able to provide a very customized denture and not have the ability to check or provide a fully balanced occlusion. That's a drawback. Otherwise, and the try-in, but that we can overcome with that functional try-in I showed you before. Those are the main drawbacks that I see at this time.
Well, thank you, Doctor. We could use one last question to wrap up with.
So we know that the mandibular movement and the hinge axis is important, especially with a complete denture. So how can we transfer it virtual to the software? So some of the systems do have ways that they incorporate what we call a virtual articulator into the whole process, which means you still have to make a Facebook record, or it is some kind of a Facebook similar record to give you that information that you can put in the virtual articulator. I haven't seen the need for that yet with the type of patients that we see. So just to give you another idea, 20% of our patients at this time, we still use the traditional way with a good old Facebook setup and so on. 80%, mainly our elderly patients, we use this technology, and we've been doing very well for the time being. But to go in the future here, what I foresee at the future is to be able to use a CBCT possibly, and instead of having a virtual articulator, actually have the virtual exact patient's mouth and movement, if we can, into this. I don't know if that can happen, but that's what we will be looking probably.
Once again, thank you very, very much, Doctor, and thank you, ladies and gentlemen, for your wonderful attendance. And also, we would like to note that all Saudi Prosthodontic Society members will receive their certificates through their email accounts, and any of who would like to join us to be a member, they could just scan the barcode in this slide and register. And we'd like also to remind you of the 3 wonderful prizes that we have to all of who answer the questions correctly in Twitter, and they will receive 3 beautiful prizes. You could go to IDS conference in Germany, or you could receive a camera, a DSLR camera worth of 7,000 riyals. I'd like to remind you also to stay tuned for tomorrow's lectures by Dr. Hisham Mousali. This was your host, Faisal Zghabi. Stay safe, stay home. Good night and goodbye, ladies and gentlemen.